Hello, everyone. Welcome back to the Physical Therapy San Pedro podcast. We are in our ankle series, and today we're going to be discussing Achilles tendon ruptures and repairs. I am your host, Dr. Janae Brown, and I am joined by my amazing team of physical therapists. To my left is
Dr. Bay.
And to my right,
Dr. D.
And
I'm Dr. Sandoval. Further right.
Further right. Yes. So we are going to dive into this. Dr. D, he wrote this blog for us.
Yep.
And why don't you share with us just a little bit about why you chose this topic, why this was interesting to you, and why you wrote it?
I think the timing worked out pretty well because, we do play fantasy football at our work. And obviously with fantasy football and just football in general, there's a lot of Achilles tendon injuries.
Thank you, Vanna White.
And obviously the biggest news recently was Aaron Rodgers tearing his Achilles tendon, basically 75 seconds into the game. It was detrimental for probably a lot of teams, but especially for the Jets fans. But I thought it would be really interesting to talk about the rehab, certain other considerations that can contribute to Achilles tendon injuries as well. So that'd be fun to talk about.
Yeah. I was going to say, if I asked you who Aaron Rodgers is, you might get upset. So
What?
I'm just going to leave it there.
Yeah, let's just leave it there.
I don't know.
I mean, I did once I read Dr. D's blog, but
What?
it's so bad. I am not the football fan here, which is why I got kicked out of fantasy football for not playing.
True story.
Which is fine by me because it was a lot of work that I didn't have to do. So I'm good.
Wait,
You didn't put any work in.
I know. Well, that's the point. I knew it was going to be work. Therefore, I didn't do the work. Therefore, I didn't win. Therefore, we're back.
Let's just remember how she thought she could win by not doing any work.
I did.
Did
But
that work out for you?
No, it was a test. It was like a little let's see what
And
happened.
what was the outcome?
Well, basically it
You
proved
can't
to
answer
show,
that question.
Well, no, it proved to show that if you don't put in the work, you can't win, right? So it was a
But-
good lesson.
So the outcome was.
But it was a
She
whole
still did better than him.
Nope.
Oh, yes.
I wasn't the sorest loser. So then
talking
maybe
about that.
it works. It just you can't get number one.
No.
It wasn't bad. Could have been worse.
Could have been worse. Okay, well, speaking of him, we're going to have Dr. Sandoval take us into anatomy, and he's going to let us know a little bit
Someone give him a tissue first. I think he's crying.
Yeah, I think
Uh-oh.
I'm not crying. I am
doing
doing
well.
very well this year.
Yeah.
But
Okay.
I'm trying to stay humble for now.
Be humble. Someone said that.
For now.
Okay, so take us into anatomy and tell us a little bit about the types of tendon ruptures that we see.
Yes. So here with my trusty model, you can see that the Achilles tendon sits right back here behind the ankle.
Beautiful taping technique.
Oh my God, it's the best. I've been practicing. This is this is the thickest tendon that we have in our bodies. It's a blend of two different tendons from the gastrocnemius and the soleus. They kind of blend into one thick fibrous tissue, and it inserts on the calcaneus right down here. And so when the gastroc-soleus complex contracts, that allows for your foot to plantar flex. So your foot does this right here. So you're pushing off through your toes because that gastroc-soleus complex pulls up on your heel and it pushes you forward. Now, you can have two different types of tears. You can have what's called a partial tear, which is just a piece of the Achilles that's now torn. Or you can have a full tear where this entire structure right back here tears. That's really pretty much it.
Yep.
If you want to see it, it's this right here.
Ooh.
Partial. And then a full.
Love it. That
And
was
it
a
just
great
flaps
demo.
in the wind like that.
It shrivels up, actually.
Yeah, so retraction.
Yes.
I don't know if shrivels up is the right word.
It's not the right word, but you can imagine it shrivels upward.
It's an easy thing to imagine, shriveling.
Mm-hmm.
So I think it's a good word.
Yeah, I forgot the actual word for it. What's the actual word?
Retracts.
Yeah,
I just
that one.
said
Yeah,
that.
she said it.
Oh,
Already.
true. Yeah.
Do you see how he's looking for help, even though he had this really
Yeah.
small portion and he still looked for some help?
I wrote
maybe
my notes.
Maybe you should write more words down.
Anyways.
That was for Dr. D. Little dig.
Thank you.
You're welcome. All right. So I'm going to take us in. That was wonderful. Thank you for the demo. And, you know,
my
Live
pleasure.
action.
I felt like it was good. Yeah. I liked it.
I'll be here all week.
It sounds good.
So.
All right. Well, I'm going to take us into symptoms and mechanism of injury. So some things that one might experience if they ruptured their Achilles or ruptured their Achilles is feeling kicked in the calf. So feeling like someone kicked you in the calf and you're like, oh, that could be an Achilles rupture. An inability to push off when you're walking. So pushing off your toes as you're going through the gait cycle. If you have difficulty coming up and standing on your toes, coming all up on the balls of your feet, a popping or snapping sensation upon injury could be a symptom, or pain. And pain can be dependent upon whether or not it's a full rupture or a complete rupture or a partial. So if it's full, we won't really have pain. It'll kind of just be, you might have some sort of sensation initially, but you won't have ongoing pain. But if your fibers are still intact, then you have pain because there's sensory information still happening in that area. So that is our symptoms. Those are the things you're going to find. Mechanism of injury. We find this often happens from an acute loading when you're either accelerating or decelerating. So when you're speeding up or slowing down, could be a way that this occurs. It could be landing from a jump. So if you jump up in the air in multiple fashions, whether you're in sport or whether you're working out at the gym, a quick change of direction. So going one way and then changing direction, going the other way. Or sometimes we find that these are some things that build up over time. So a person who has a degenerative tendon, maybe just from over stress or overloading or overworking that tendon, we can see that sometimes the degenerative stress leads to like slow tearing and then like a full rupture as well. So my part was kind of easy, I think.
Yeah, you want to do the rest?
No, not really. I think that we should let Dr. D, who wrote this wonderful post about this, just very thorough, right? Takes us through all this stuff. I think he should just share with us all of the information that's in his brain. So we're going to lead into him, and he's going to take us through the phases of rehabilitation, which is actually the most exciting part because that's what we do. We love it, and we get to do it with you guys every day. So, Dr. D, let's talk a little bit about it, and we can also just chat together, like, you know, on some of these phases as we go through. Let us know, you know, what rehab looks like for someone who ruptures.
So I kind of just broke it down into 5 phases, depending on which surgeon you go to. The phases could be a little bit different, could be shorter, it could be a little bit longer. Timelines could obviously vary as well, but generally speaking, it starts off with just the early post-op phase. When you're non-weight bearing, you can't put any weight on it. You usually have a boot on it as well, but we try to focus on strength work outside of obviously the Achilles aspect because we're not able to load it yet. I typically like to do BFR right off the bat as much as possible so that we can minimize the strength losses and the muscle mass losses. Not everybody has access to that, but I think that's an easier way of introducing that aspect before we get into the strength things later on without losing too much of it. So it's pretty simple. I think early post-op, I think it's first 3 to 4 weeks or so. I think you're non-weight bearing. Obviously things are progressing along the way, but once you get into the later stages or phase 2, what I would call it, for a late post-op, that's when your weight bearing starts to increase. We can sometimes measure it by putting yourself on a weight scale to see how much weight we're actually putting onto it relative to your entire body weight. Range of motion work starts to get added on here, but we're still limited in dorsiflexion. So Dr. Sandoval said plantar flexion was going this way, right? So dorsiflexion is when your toes are going upward. We want to minimize that because that would put a lot more stress onto the Achilles tendon to begin with. So
Mhm.
at that point, we're still not pushing that aspect of it. And we also have a heel wedge typically when you're first starting out in the boot. Some surgeons will put more than others probably, but the goal is to slowly take one of those wedges away until we can get into that neutral position of your ankle. So that's the first goal when it comes to phase 2, is getting towards regular walking essentially without the heel wedge or the heel lift. And going into more of the transitional phase, this is where it starts to kind of get a little gray depending on what surgeon that you're going to. We're slowly starting to increase that dorsiflexion range of motion, putting a little bit more stress on that Achilles little by little, more so in the active fashion first than the passive fashion. And starting to work on gait mechanics, how well we can walk, normalizing all those things, balance work, starting to work on some calf strength, but not standing obviously at the very beginning. We'll usually start in seated positions, unloading it a little bit so that we can slowly start to progress the load that we put onto that Achilles tendon or the calf complex too. Then phase 4, phase 5 is kind of a blend for the most part, right? Strength, functional strength, return to sport. This is the part where it's probably the longest for most athletes, because for the first 3 phases, you're not really building too much strength in your calf or your Achilles as far as load capacity goes. So this is usually the longest part, the most intensive part, going into plyometrics and your squats, your deads, all those kinds of things start to get incorporated here, and working towards more reactive drills. I think one thing that when it comes to plyometrics, we can kind of talk about this one, but we focus so much on plyometrics going forward that we don't do, I know me and Dr. Bay have talked about this recently, but we don't do enough plyometrics going backwards as well. When you see a lot of athletes right now, it's usually when things are getting stressed, maybe later on in maybe the third quarter or something, where you've already stressed your calf and your Achilles a pretty significant amount. A lot of times just one step going back can just snap it as well. So reverse plyometrics or backward plyometrics play a lot more into it as well. So because that puts a lot more stress on the Achilles tendon too. So yeah, and then the rest is gradually returning to the sport, getting it incorporated back onto the field, court, whatever sport it may be.
Stage.
What? Or stage, yes, exactly, for the dancers. Then yeah, just going into the progressions of individual drills, non-contact drills, starting to add more variables little by little until we're ready to go, ready to get on the field fully. So, yep.
Oh, that was great. We didn't even have to step in.
I don't think I gave you guys a chance to step.
That was wonderful.
That was amazing.
You didn't need to write anything down.
That's why you're the professor.
Oh, God.
You're such a great teacher. Tell us more. Tell us more. I'm just kidding.
That was enough.
He's like, I'm good. All right. So those are the phases of rehab. I think let's dive into other considerations first, and then let's circle back and talk a little bit about patients that we've seen that have had ruptures. We can talk a little more about just things that we do specifically in those phases as well. Dr. Bay, give us some other considerations.
Yes, definitely. There's some other considerations that are going to increase our risk for injury to the Achilles tendon. And a big one is specializing in a sport too early. So research has shown that in the gymnastics population, specializing before the age of 10 is going to result in a higher risk. Another one is over-specialization. Certain positions within sports, football, for example, our defensive ends and linebackers are going to have so much repetition to their movements that we're really going to have an overload situation for that Achilles and very prone to injury there as well. Also in the NFL, there's suspect to the variability of the surfaces. 30 different playing fields are available for use in the NFL. And while they haven't found a correlation between grass versus turf, just the huge difference in surfaces from field to field may be related to the increased stress to the tendon. And the last big one we want to talk about is footwear. Different sole types are going to stress our tendon differently. So a stiff sole is going to maybe increase our performance, but also in turn increase the stress on the tendon. A foam sole might reduce load, but it's going to change our foot's ability to sense where it is in space, which also can put it at risk to injure, unfortunately. And then if there's too much traction in your shoe or your shoe is lightweight and it might break down more easily. Those are all considerations that might put us at more risk for injury.
Lots of good stuff. It's like all this meat, and we just need to talk about it all. So, okay, so
Go.
let's start with patients that we've seen. And I know Dr. D specifically, you recently had a patient that went all the way through the phases from like rupture to the end of this. So talk to us about like that. Did you know that was he at risk for rupturing prior? Was this something that, kind of came out of the blue? Would you say anything in regards to this particular patient in terms of the rupture? Because I knew you knew the patient.
So I saw this gentleman previously when he tore his ACL. So I rehabbed him through the entire ACL progression as far as the rehab goes, and made him a strength program, plyometric program, made him everything, but
Was it the same side?
Opposite side,
Okay.
actually. And like I won't say all, but a lot of patients, unfortunately, they kind of fall off after whether life happens or rehab stops. And he didn't really continue to do any of the work that I provided him. And he knows that too, because he told me about it. And he was like, okay, I'm going to help my friend coach soccer. So he started coaching it, and lo and behold, he didn't really do anything in particular. He was kind of just jogging, and it's just a quick change in direction, nothing rapid, and it was gone.
Do you remember seeing anything this might be hard for you to recall, but in his ACL rehab that made you think that there were issues in his Achilles tendons at that time, or weakness in his foot and ankle, or anything in relation to how he moved that might have impacted that at all? No.
Way too long ago.
Way too long ago. Hard to remember. Because we do see like a lot of these injuries where it's like ACL tear, then, another something else happens. But, like these, I'm trying to think of one recently, but we do see in sports where someone goes out and then we send them back too early, and then we see something else happen. And I'm wondering, do you remember the time frame and difference in time frame from when from the ACL to the Achilles? Was it like a year or two?
Yeah, it was a year after.
1 year.
Sorry, 2 years after the ACL reconstruction. Yeah.
Interesting. And you rehabbed him like a full year for his ACL?
Yeah, pretty close to a full year.
Yeah, it's interesting when we see and these are big injuries. It's not like, you know what I mean, ACL, then you sprain your ankle, or ACL, and then you get some like patellar tendonitis, or just something that's maybe related. Sometimes when it's related, it's a little easier to understand, but when it's unrelated and such a large injury, it's like, what are some of these correlations? Has anybody else had an Achilles tendon rupture patient recently? No,
not for a long time.
No, not for a long time. I recently had a strong woman who I believe she tore her Achilles, not full. It wasn't a full rupture. But a lot of her tests made it look like it was hard because the test can show it. And I sent her off for imaging and follow up, and she ended up not following through with it. But then she's like, now we're months and months later, and she's like fully rehabbed it. So
nice.
I mean, I guess it's there, but yeah, it's interesting. Okay. So what about the rehab process? The rehab process, what do you think, Dr. D, with him was the hardest part about the rehab process? Because this is this is an interesting case because you took him from beginning to the end. Sometimes we get patients like in the middle. Sometimes we don't see them through the full process. Got to kind of see him like from start to finish. So what would you say the hardest part of the rehab process was?
Building calf strength through the full range of motion.
Building calf strength.
That was the hardest part. And he said the same thing too. And I think Kevin Durant said the same thing too when he tore his. And well, kind of going into Kevin Durant's thing, but he basically said like take more time off so that the strength comes back fully. Because he said that was like the biggest thing that contributed to him to building back his performance again on the court.
Yeah.
And I felt the same way for him too. That's the part that took a lot longer compared to all the sprinting, plyos, all that kind of stuff progressed pretty well overall.
Mm-hmm.
But getting the strength back in full range was challenging. Yeah.
Now,
At
do you
least for
mean
me.
coming out of a deficit, being able to come out of a deficit with
Both?
Okay.
Yeah, both the fully dorsiflex position and both the fully plantar flex position as well. I think that was the hardest part
That's interesting.
because I've had like 4 or 5 Achilles
Oh.
rupture patients in the past,
So you're our Achilles guy.
and that was the hardest for probably all of them for me. Yeah.
Interesting. Have the patients you worked with in the past that have had Achilles, since you had so many, would you say that they were all able to get to their full potential and back to how they were moving prior and back to sport? They were. So do you feel like it's basically possible as you go through the rehab process to get there? What was the time frame, if you were to say average time frame of the 4 to 5, that you would tell people would take from beginning to end for a successful return to sport rehab?
What's the end? What do you mean by the end?
1 year, 6 months, 8,
Or
9
sorry,
months,
what's the goal? Like back to competition?
or back to sport, or yeah.
Back to sport, I feel like is a lot earlier.
Okay.
I would say like 8, 9 months.
Okay.
I would say safely.
Mm-hmm.
But return to competition, I think fully competitively is about a year, in my opinion. Yeah.
And what about testing? Like, do you guys feel like we have good testing for returning these particular? It's hard because these are our Achilles tendon ruptures are probably they're way more rare than ACL. Like we don't see them as often, right, in clinic. So testing wise, do you feel like we have good tests and measures in place to return? Did you feel like you had good tests and measures in place to return your patient back to sport or back to play?
I use probably similar tests to my ACL
Okay.
protocols for the most part.
Okay.
Some of them I would do because we have like single leg hops, triple hops, but all those are forward.
Mm-hmm.
So I would do like a reverse hop distance too.
Okay.
Just to make sure that they can completely decelerate themselves by stepping backwards. So that was probably the one unique test that I used for Achilles tendon testing.
Okay.
Yeah. But other than that, I would probably say it's relatively similar. Hop tests and stuff like that, strength tests.
Yeah.
Yeah.
Okay, so let's go into fantasy football that you guys are all participating in and watching week to week football. You mentioned some players, which I'm not going to try to rename myself, in your blog post, that have had ruptures, and you told me that it was some were preseason, some were in the season. Are there any correlations? Do you guys see any correlations to them? You might have mentioned some also in the blog, but what are some correlations if you guys know any, and with any of the players? Chat.
I think one of the things, this is something that Dr. Bay and Dr. D and I spoke about earlier. I think one of the things that plays a huge role into this is overuse and just repetitive use over time. It might not necessarily be overuse because they may not be feeling any type of symptom, but just repetitive use over time, I think is one of the hugest factors in this particular sport.
Okay. Concur, you guys?
Definitely.
Yeah.
Yeah. I think where some things could be said as far as off-season, preseason goes, and also rookies and players that may potentially be cut is the workload they have to put in during the preseason because they're trying to make the 53-man roster and they're probably trying to be on the field for as long as possible. And a lot of times that can contribute to overloading some of those tissues at the same time as well. So I think depending on where they are in their status of that roster can also play a part as well. Because if you already know you're going to play, the coaches typically will hold back on putting them on the field as far as
yeah, that makes sense.
Right, because certain players just tend to get injured more. Like Austin Eckler gets injured quite a bit, but that's because he's on the field a lot, and he complained about it too. But I think that plays a part as well. Rookies, obviously, they're not they haven't played at that intensity yet either. So I think sometimes in the off season and preseason they get injured there as well.
What about by position? Are there certain positions that we see across the NFL?
Yeah, so she mentioned defensive ends and linebackers. They tend to be the players that get this injury the most. I was thinking about it. Those positions, they are contact heavy positions. They're always running into and absorbing forces from other players.
Mhm.
And I think that plays a huge role into having that excessive eccentric loading on that Achilles as they potentially take a step back when they're getting hit or when they are hitting. I think that's probably something that's affecting them more so than other players, right? It's that step backward that Dr. D was talking about earlier that really causes that excessive eccentric loading on that Achilles, especially when you have somebody else running full force at you at 20 miles per hour. That's a lot of load on that Achilles, and that's probably what contributes to them, that position group, seeing this injury more so than others.
Yeah. And they're typically going in the same direction almost every play as well.
Mm-hmm.
So I think that's why the over specialization kind of comes in, is they're always taking, it's always not completely the same, but the direction is, the target's the same thing, right? They're
Like if they always line up on one side of the field,
right,
they're always going
they're
to the
always
right.
going to cut in a certain direction. And they're having to go against like 300-pound dudes. So it's a lot.
Mm-hmm.
Did you guys see any of the injuries that have happened so far in play? Did anybody see them happen? Mm-hmm. They line up, like, what was the mechanism of injury with the ones that you guys have seen?
Rogers was
typically it's someone landing on you or just like going. You mean for the specific injury?
Well, I was wondering. Yeah, no. I was wondering. Did any of them that you saw actually suffer the injury line up with the mechanism of injury that we're talking about? So is it like
Aaron Rodgers was a step back,
right?
Sort of.
I think he was getting tackled.
It was like a scramble. He got tackled, and then the defensive lineman landed on top of him as his foot was dorsiflexing.
Yeah. Yeah. So it was like a forced one.
Ouch.
For the most part. Yeah.
And he was a complete rupture. Do we know?
I believe so.
Yeah.
He already got it done. So
yeah. Interesting. Specialization. There were a few things you talked about. So we talked about player specific. What about other sports? Is there any other sports we see this occur in?
Well, I think dancers, because of the jumping.
Okay.
Yeah.
Dancers. Anybody else? Any other group?
Sometimes in jiu-jitsu, because there's specific techniques that are made to tear your Achilles.
Yeah.
Really?
Jeez.
So we see it sometimes.
That's so nice.
But,
for sure.
yeah.
Definitely basketball. We see it in
basketball, volleyball,
a lot.
the jumping, the eccentric loading as you're landing. Yeah.
So basically, if you're in a jumping sport, this is something that you need to be.
Or just with dance, going up on point, the extra load on the Achilles is a very common complaint.
Rupture or more tendonitis? Do you
Tendonitis,
see?
but the ruptures are seen with jumps.
Yeah.
Mm-hmm.
Yeah. Okay. Other considerations or anything we want to talk about in regards to these other considerations? Talk about footwear. Do you guys have any thoughts on footwear or anything that you think we need to share more than what was shared already by Dr. Bay?
I think it's pretty clear. I mean, she basically said it right. It's like there's no one right shoe for anything.
Yep.
You just have to think about, what type of surface we're on, what shoe fits you, things like that. But
what about anatomy? Is there anything anatomy-wise that would make someone prone to this particular injury? Do you guys think if someone had more of a supinated foot, pronated foot, if they had like more external rotated hips is there anything that we see that you guys have came across in seeing patients like this, or just reading literature, anything that would make you think that would impact? Thoughts?
I mean, you want to be really specific, then if you probably lack internal rotation in the tibia, then it would probably compromise that too, because you're probably not going to have as much dorsiflexion in the ankle. And if you don't have as much of that, and you're like Aaron Rodgers and you get pushed into it, then you're probably going to tear it.
So lacking dorsiflexion is basically another kind of precursor there. Yeah. Yeah. It's good stuff.
I lack dorsiflexion on my left side, and that's my Achilles irritable side. Makes sense.
Yeah. All right. Do we have any other thoughts about this this Achilles tendon rupture injury? Thoughts? We talked a lot about stuff. We gave them, I think we gave you guys a good sort of understanding of what this injury is and how it occurs. So hopefully you learned something new. And if you did not, and you want to learn more from us, or you need help with your Achilles, maybe you have an Achilles injury, you have some tendonitis, maybe you ruptured, maybe you have a partial tear, you can work with us. We work with patients in the clinic. We work with patients virtually. So if you're interested in working with us, you can go on our website. You can go on our Instagram. You can click on the links there and book an appointment directly. You could be working directly with Dr. D or Dr. Bay or Dr. Sandoval. So they're the best. So if you need some help, they're here for you. We're here for you. We also, just a few things going on in our clinic. We have this full video will be up on our YouTube channel. Our YouTube channel is live. So if you're looking for more discussions on different injuries that you might be suffering from, check out our YouTube channel. You can subscribe it, comment, share with us, anything you want to share about these videos, give us some feedback. We'd love to hear it from you. We also have our podcast up on your favorite channels. So go binge listen to that. We have 36 episodes up now. So we are just racking them up. So yeah, go listen on your favorite channel, share a comment, subscribe, all that stuff. And you can always find out more information about our clinic on our website at physicaltherapysanpedro.com. I think that's it. Thank you guys for being a part of our community here and for tuning in each week. We'll see you next time. Bye.